Hello class, this is our lecture on care of the patient with eye and vision problems. First we'll begin with discussing the features or the structures of the external eye. First we have the eyebrows, eyelids, and eyelashes, and the purpose of these structures are to protect the eye from dust and foreign particles. Also, the eyelids are responsible for the distribution of tears, and the eyelids help to control the amount of light that enter our visual pathways. Next, we have the conjunctiva or the conjunctiva, and it covers the inner surface of the eyelids, and this is also known as the palpebral conjunctiva. It should also be noted that it extends over the sclera, and it's responsible for secreting mucus and tears. Mucous membranes are what are there to protect our eyes. It also, when we talk about the conjunctiva and the sclera, we have to note that they lack a blood supply. So by knowing that, that helps us to know that when the person has an infection, they're going to have, a unique problem because it lacks a blood supply. Also, we have to discuss the sclera. The sclera is the white or opaque part of the eye, and the sclera is responsible for protecting the intraocular structure, so inside of the eye. The sclera has a tough shell. Then we have, we can't see it, but in the anterior cavity of the eye, we have a solution that's called aqueous humor. Aqueous humor is maintained at a constant level, so the body is constantly manufacturing aqueous humor and reabsorbing aqueous humor into the bloodstream, and so it's continually being manufactured because it's responsible for maintaining intraocular pressure. If you'll look at in your book at one of the diagrams of the eye and locate the canal of Schlemm, it's important that you note this structure because the canal of Schlemm is where aqueous humor is drained into the bloodstream. Also, in addition to aqueous humor that's in the anterior cavity of the eye, there's also vitreous humor, and vitreous humor is in the posterior cavity of the eye. And so both of these solutions work together to help maintain the shape of the eye. And again, it should be noted that aqueous humor is responsible for maintaining intraocular pressure. And so when we talk about intraocular pressure, the normal IOP is 10 to 21 millimeters of mercury. Also, with the external eye, the cornea. The cornea is where light enters the eye. It's a clear coat that is on the. It's a clear coat on the front of the eye. So now we'll discuss the internal structures of the eye. First, we can discuss the iris. The iris is the color portion of the eye. The iris contains the pupil, which allows light to enter the eye. And so this is just a question for you to answer yourself. What happens when we enter a darkened room? When we enter a darkened room, it causes the pupil to dilate. And so the pupil dilates when we enter a darkened room so that more light can enter the eye. And so there are terms discussed in your book for pupil dilation and pupillary constriction. So miosis is pupillary constriction and mydriasis is dilation. Next, we'll discuss the lens. The lens lies behind the iris, and the function of the lens is to bend light rays so that they fall onto the retina. So again, the lens is responsible for bending light rays so that they fall onto the retina. Then we have the retina. And so the retina is the innermost layer of the eye. It is responsible for converting images into a form that the brain can understand and process for vision. Also, the retina is responsible for transmitting impulses to the optic nerve. So the retina is going to be responsible for our central vision, peripheral vision, and color perception. So needless to say, if we have a problem with the retina, then the person is possibly going to be blind if they have problems with the retina. So when we're talking, when we're doing an assessment, a history and physical on our patient, and we think that they're having problems with the eye, we can ask them about their past health history. We can ask them about disorders such as diabetes. We can inquire about hypertension, any type of cardiac disorders. We can ask them about any type of eye exams, when they've had their last eye exam. And this is going to be important. Throughout this lecture, we're going to learn how important it is to have yearly eye exams, why they're so important. And so we want to ask them, when was their last eye exam? Ask them, have they ever had the pressures in their eyes tested before? We can ask them about any previous eye trauma. Traumas that happen early in life can lead to problems in later life. So we want to know about any traumas. We can assess visual acuity, and we'll talk about that a little bit later, but we usually check for visual acuity by the use of a Snellen chart or a Jaeger chart, and we'll look at those later. When we look at the abbreviations OU, OD, and OS, OU refers to both eyes, OD is the right eye, and OS is the left eye. PERLA, we should all know that. That's pupils are equal, round, reactive to light, and accommodation. And then we have accommodation. We have that by itself. And so the way that we test for accommodation is that we have the patient to focus on a distant object, and then as the person is focusing on that distant object, we have the person to focus on a close object. And so when the person does this, the pupils should converge and the pupils should dilate. And so that's how we check for accommodation. And so now that we've done a really brief review of the structures of the internal and external eye, I want to move on and talk about different infections. And so these infections that we're going to discuss, for the most part, they deal with the external eye. Blepharitis is the first one that we'll discuss. And so as it says here, it's an inflammation of the eyelid edges. It's characterized by itching, redness, burning eyes. And so blepharitis is a common and persistent inflammation of the eyelids. And so as we see the symptoms here, the person may occasionally have red eye. And blepharitis usually or frequently occurs in people that have oily skin, that have problems with dandruff, and also people that have problems with dry eyes. And so one of the things that the person is affected with is it says here a seborrhea of the eyebrows and eyelids with greasy scales and matters. And so this is like a little cartoon depiction of a person with blepharitis, but really it's kind of an accurate picture. The person has this scaling redness that occurs on the eyelid edges. And so usually the treatment for this is we encourage the person to use warm compresses for comfort, and then we encourage this person to do what is called a lid scrub. The lid scrub is done with baby shampoo. And so when I was reading this and when I read in the book, I wondered, well, why are we using a baby shampoo, a no tears baby shampoo for this? Well, it's a problem of the oil glands, and also it's like a dandruff problem, and we use shampoo for dandruff, and so that's why we use the baby shampoo for the person that has blepharitis. And so the way that we teach a person to do an eyelid scrub is that we want the person to wash their hands thoroughly. We're going to tell them to mix the non-irritating baby shampoo with warm water. They're going to use a clean cloth, and if they have it on both eyes, they're going to use a separate cloth for each eye. And so they're going to rub the solution back and forth over the over the eyelashes and the edge of the closed eyelid. So the person doesn't have their eye open, rubbing baby shampoo in the eye. They have the eye closed and they're scrubbing the edges of the eyelid. Once they finish with that, they're going to rinse with clear water. And like I said, if this problem is occurring in both eyes, they're going to perform the same procedure on the other eye, but preferably they're going to do that with a clean towel. The reason that the eyelid scrub is performed is that what usually occurs with this, as I said, it's a problem with usually the person has too much oil in their skin, and so what happens is the eyelids can become blocked with that oil. And so the way that we get that oil out is that we massage it, and so that eyelid scrub with the baby shampoo is a way of massaging that oil out of the eyelids. And so the person, as I said, the baby shampoo, maybe if the person has dry eyes, they may need wetting drops. Also, if it's a lady that's being affected with this infection, well, we would want to encourage her to stop using eye makeup until the infection is gone. If the person wears contact lenses, well, they probably will want to discontinue the use of the contact lenses during the treatment. And so there is a chart in your book that talks about the installation of ophthalmic ointment in the eye. So just make sure you read over that information. The book says ideally you want to have on gloves. Well, the person in this picture don't have on gloves, but they want us to have on gloves. We should always work from inner to outer, so inner canthus to the outer canthus. If possible, the book mentions that we're going to use separate bottles. And this is just something that the book says, but as a mother that has purchased eye drops before that are about $60, you're not going to get 2 bottles of it. And so what we want to make sure that the person knows is to be really careful with the tips of an ointment or an eye drop, and that they're being careful not to touch the tip of that to any part of the eye. The reason for that is that we can transmit the infection from one eye to the other by way of that bottle. So we want to make sure that we don't touch the bottle to any part of the eye. And if we have a patient and we're using an ointment, the way that we're going to use remove excessive ointment is to have the person to close their eyes, and then we're going to gently remove that excess ointment with the tissue while the person's eye is closed. When we have a person that has an infection in the eye and we're teaching them about cleaning the eyes, we want to always make sure that they know that they either use 2 washcloths or use different sections of the washcloth for both eyes. And so a hordeolum, also we typically know it as a sty. As it says here, that a sty can be internal or a sty can be external. When it's an internal sty, it forms within the conjunctiva of the eye. And so the conjunctiva of the eye, if you pull down your bottom eyelid, that's part of your conjunctiva. And so it can be either internal or external. And so the treatment for a sty, really the only treatment, the person can use warm compresses 4 times a day with the antibacterial ointment. And we've already talked about how to remove excessive ointment if the person has a lot of ointment. We want the person to make sure they keep their eyes closed when we're installing ointment in the eyes. Now, a Chalazion kind of looks like a sty. Now, the difference in helping us to differentiate a Chalazion from a sty, one thing is a sty is quite painful to the person that's dealing with it. On the other hand, a Chalazion is typically not painful, but Chalazions tend to be larger. Also, sties don't usually obstruct the person's vision, whereas a Chalazion can, because if you notice the difference between the two of them, Chalazions tend to be a little bit larger. And so the person may have eye fatigue that develops simply because the eye isn't closing completely, and so the person may have light sensitivity, and they may have excessive tears that result. And so that's what it says up under this slide. I'm sorry that I covered the words up, but all it says here is that the person can have eye fatigue, light sensitivity, and excessive tears to result. And so, again, what should be noted is that a chalazion is an inflammation of the sebaceous glands, whereas a sty is typically inflammation of the sweat glands. So we're talking about oil versus sweat. Chalazions can obstruct vision, but they're usually not painful. And so those are a couple of ways to distinguish the two from one another, because they kind of look alike, and the treatment for both of them are typically the same. The treatment for chalazion, just the same as a sty. You want the person to use warm compresses up to 4 times a day and use ophthalmic ointment. Usually with the chalazion, the person they usually resolve themselves after several months. If it does not resolve itself, then the person may require surgery to remove a chalazion. And conjunctivitis. Conjunctivitis, let's make sure we remember that the conjunctiva is the portion of the eye. It covers the inside of the eyelid, and the conjunctiva extends over the sclera. It should also be noted, I also want you to remember that we said the conjunctiva and the sclera also lack a blood supply. Okay, so when the person has conjunctivitis, conjunctivitis can be allergic conjunctivitis, bacterial, or it can be viral. And so how would we determine which of the three it is? We would determine that by doing a culture. Okay? And so the culture would help us to determine, if it's bacterial, if it's allergic, if it's viral. And then we could also look at the characteristics. So in your book, it says that when a person has an allergic conjunctivitis, the person is going to have red eyes because the person has an engorgement of the blood vessels, which cause the eyes to have a bloodshot appearance. They may also complain of burning, but this person usually doesn't have any discharge with the allergic type of conjunctivitis. And so usually what this person will use in treatment of allergic conjunctivitis is vasoconstrictors. Well, it makes sense that we're going to use vasoconstrictors because we said this person has an engorgement of blood vessels or a dilation of blood vessels. So we give this person with allergic type vasoconstrictors, whereas the person with the bacterial type, which we typically know as pink eye, this person is going to have tearing. They may also have the red eye, the pink eye that we typically see, but it should be noted that the person with the bacterial type is also going to have a thick mucus with the bacterial type of conjunctivitis. So most allergies, as we know, they're not contagious. So allergic conjunctivitis is not contagious, whereas the bacterial conjunctivitis, pink eye, it is very contagious. And so what we have to note, what we have to be careful and know to teach our patients and our children when they have pink eye, make sure they're constantly washing their hands, trying not to rub the eyes, making sure that they're not rubbing one eye and then rubbing the other, because typically when kids have pink eye in one eye, they're going to get it in the other because they're rubbing both eyes. If this is an older person that has conjunctivitis, well then they, close contacts are at risk for developing it, so they may not want to share bed linens, share the same pillows. Just be making sure they're careful with any type of things that they're coming into close contact with. Making sure they know the proper way to instill eye drops, and we talked about that, being careful not to touch any part of the eye dropper to any part of the infected eye. Also, when the person is washing the face, being careful not to wash the unaffected eye with the same portion that they've washed the affected eye. So when we talk about corneal conditions, Keratitis is the condition that we're going to discuss when we talk about corneal disorders. The book talks about some different things, but we're going to specifically talk about keratitis. And so keratitis is the medical term for inflammation of the cornea. And so we talked about the cornea briefly, but the cornea is responsible for bending light rays to the retina. And so the cornea accounts for approximately 2/3 of the eye's total optical power. So if the cornea is affected, well, then we've taken away 2/3 of the optical power of our eyes. So we really want to take care of our corneas. And so reasons that a person develops keratitis, there are various types of reasons. Different types of infections can lead to infections of the cornea. A person with chronic dry eyes is at risk for developing keratitis. Injuries can lead to keratitis. And so some types of keratitis develop for unknown reasons. And so major risk factors for the development of keratitis, a person that wears contact lenses and they don't practice proper hygiene. So that means the person may use improper solutions. The person may overwear their contact lenses. We're supposed to take them out every night. So the person that, wears daily contact lenses for a week, well, then they're at risk for developing keratitis. When we talk about signs and symptoms of keratitis, the person may complain of pain, tearing, blurred vision. The person may have mild to severe pain, and that's going to depend on the extent of the inflammation. Also, the person may report that they have sensitivity to light. The person's eye may be red, watery. And so when you look at keratitis, it makes sense that we've got to distinguish keratitis from conjunctivitis, which we just talked about, because the person with conjunctivitis also had that red appearance of the eye, especially when we talked about the allergic type of conjunctivitis. So again, we may have to do a culture to help determine what the person actually has going on. And so usually an ophthalmologist is the person that's going to diagnose keratitis and help to distinguish it from allergic conjunctivitis. As I said, the person may have a culture done. We want to determine if it's a viral cause for the keratitis. It could also be a bacterial cause or a parasitic cause for the keratitis. So again, we're going to do cultures to determine what the causative agent is, and then we're going to treat it. And so usually, we use antibiotics for bacteria. The person may need, of course, eye drops may be needed. Wetting drops could help. Also, the person may need steroid drops, and the steroid drops are going to help reduce inflammation, and they're also going to limit scarring that can occur because of the keratitis infection or the corneal infection. Now we're going to move on into the section where we talk about disorders. And so as you see here, we're going to discuss cataracts, glaucoma, retinal detachment, macular degeneration, retinitis pigmentosus, and also we're going to briefly discuss cancers that can develop. Okay, first to begin with talking about cataracts. First, we need to go back to what the purpose of the lens of the eye is for. Okay, so again, the lens of the eye is behind the iris. The function of the lens is to bend light rays so that they fall onto the retina. So again, the lens of the eye is responsible for bending light rays so that they fall onto the retina. Now, when the person has a cataract to develop, what is a cataract? A cataract is an opacity of the lens. And so anytime we talk about opaque, it's something that was once clear, and it's a clouding or a whiteness that occurs. And so you have an area that's clear that you can no longer see through. And so when this opacity occurs, the opacity of the lens, it distorts the image that's projected onto the retina. According to the book, it's expected in all people over the age of 80. UV light increases the risk of cataract development. And so in reading up on cataracts, I found a mnemonic that goes over the different risk factors for cataract. And so C was for congenital. A is for aging. T is for toxicity. So steroid use put a person at risk for developing cataracts. Accidents, as I said, eye injuries, eye traumas put a person at risk for cataract development. Radiation from sunlight, altered metabolism, diabetes, puts a person at risk. And also C for cigarette smoking, puts a person at risk for cataract development. And so this is just a picture here that's showing you where the opacities have occurred on this lens. And so if you note here, you see all of these little black spots. These are the opacities that have developed on this once clear lens. And so because of those opacities, when they hit the retina as little spots. And so the person was visualizing an E, but when it hits the retina, all you see are little spots because you have these opacities on the lens that are distorting the image. And so when we talk about treatment for cataract, the only way that we can treat a cataract is to remove it. And so we know that the lens has a purpose, so we can't just take the cataract out and suture the eye back up. Nope. We have to take that old opaque lens out and put a clear lens in, an artificial lens. And so the book talks about two different types of procedures for cataract removal. You have the extracapsular cataract extraction. And so it says here that the lens and the anterior portion of the eye is open and the lens is removed. And then we have this phacoemulsification, cataract extraction. Big word, huh? And so with this, it says that there's an instrument that uses sound waves. The sound waves break up the lens, the opaque lens, into little pieces, and then it sucks those old pieces out, and then the person has a new lens inserted. And so in the preoperative period for the person that's having a cataract to be removed, we want to teach them what to expect in the postoperative period. It should be noted that, and it says it in your book, most people after they have a cataract removed and have the new lens replaced, they're going to immediately say that they have improved vision. Okay, so what we expect is improved vision. We don't expect the vision to become worse. If the person complains of worsening of their vision, well, then that is a sign of a complication after the cataract surgery. When you're reading in the assessment chapter, if you remember way back when we did health assessment, when we're doing an ophthalmoscopic exam and we use our ophthalmoscope, we're looking for a red reflex. And so in our normal population that lack cataracts, when we shine this light into the person's eye, we expect a red reflex. Well, in the patient that has a cataract that's developed, they're going to have an absent red reflex, and it's absent because the lens is opaque and they're going to lack that red reflex. So I just want you to note that when you're going back and you're doing your reading over assessment of the eye. So we talked about the preoperative period some. Usually this is going to be an outpatient procedure because there are very few complications associated with having cataract removal. And so we just want to tell the person what to expect in the postoperative period. Usually this person will need someone to carry them home. As I said, it is a outpatient procedure. We do want to make sure that the person knows that they are going to be responsible for installing or for the installation of different types of eye drops. They're going to have several different types of eye drops, and they're going to need to use those for 2 to 4 weeks. And so the person is going to be responsible for doing that, and they need to, make sure that they're going to be able to put the eye drops in, or they may need a family member to help them with those eye drops. With the intraoperative period, we just talked about the two types of procedures that can be performed: the extracapular procedure or the phacoemulsification. So with the postoperative care of this person, the person is going to need antibiotics. Antibiotics are going to be given immediately after surgery. And according to your book, the person may also have a steroid ointment, and that's just going to help to decrease inflammation. The person will not require an eye patch, but the person will need to wear dark sunglasses up to an hour after the procedure, because the eye is still going to be really sensitive to light at that point after the surgery, and so the person will want to wear dark glasses when they're entering brightly lit environments. Again, the person is we need to make sure that the person knows how to properly apply eye drops and eye ointments. We need them to know that mild itching is going to be normal. The person may have some redness. They may have a bloodshot appearance, but pain, especially severe pain, is not an expected outcome after cataract surgery. And so the person may have, some discomfort at the area where the cataract was removed, but severe pain is not usually an expected outcome after this surgery. And so if the person has pain, then it may be an indication that the person has increased intraocular pressure, or the person may have a hemorrhage that's starting to develop. And so what we want to make sure, if the person complains of severe pain or the eye starting to become more swollen, then the person needs to make sure that they call their physician. Also, we want the person to know the signs and symptoms of infection. And so if the person reports that they have a yellow or green discharge, well, then that's a sign of infection, and it must be reported to their physician. On the other hand, the person may have a white discharge that develops, a creamy white discharge. The person may have a crusty drainage that develops. That is normal. Yellow or green is not normal. Yellow or green needs to be reported to the physician, and the person also needs to assess for bleeding. Okay? So again, what do we expect? We expect that the person may have mild itching. The person may have a little swelling and bruising. The person may have some mild pain, okay? What we don't expect is severe pain. We don't expect the eye to become excessively swollen. We don't expect yellow or green discharge. All of these are signs of a complication of either maybe hemorrhage, increased intraocular pressure, or infection, and those things need to be reported to the physician. When we talk about community-based care, the book talks about home care management of this patient, making sure, as I said, that they know about instilling the eye drops, make sure that they know that the eye drops are typically, the book says, from 4 to 6 weeks after cardiac surgery. So the person needs to know how to do it, and if they can't do it, then maybe they can enlist the help of one of their family members. And of course, we want the person to report any sharp, sudden pain in the eye, bleeding, any increased discharge, lid swelling, decreased vision, flashes of light or floating shapes. We'll talk more about that later. And we want the person to avoid activities that may increase intraocular pressure. And so those things are if the person bends from the waist, lifting heavy objects over 10 pounds, sneezing and coughing, blowing the nose. And so you say, well, how can a person avoid sneezing and coughing? Maybe they can't, but one book has said that if a person has to sneeze, trying to sneeze with the mouth open, instead of how we, when we sneeze, we squinch, we close the eyes really tight. So if the person can't avoid it, we want the person to try to avoid coughing or sneezing. Straining straining while having a bowel movement. People, if this is a person and we know that this is a problem for them, when they go home, we can ask them if they need a stool softener before they leave us. The person would need to avoid tight shirt collars. Sexual intercourse will probably need to be avoided because it can increase intraocular pressure. And these things are noted for you in your book, so you can review those things. And of course, we again have to know how to properly tell a person how to use eye drops. So, the next disorder that we will discuss is glaucoma. So, as it says here, it's a group of ocular disorders resulting in increased intraocular pressure. So, the two types that we're going to talk about are your primary open-angle glaucoma and angle closure glaucoma. And so, when we talk about increased intraocular pressure, with increased pressures, we have blood vessels in the eye, we know that, but when the pressure increases, the blood vessels in the eye become obstructed. And so with this obstruction, it prevents the outflow of aqueous humor. Now remember, we talked about aqueous humor. Aqueous humor is continuously manufactured and reabsorbed into the bloodstream. Well, when the person has these pressures to continue to build up in the eye, it obstructs those blood vessels, and then the aqueous humor can't be drained through the canal of Schlemm. Now, that's what happens with your primary open-angle glaucoma. Now, with acute angle closure glaucoma, this is when a person has movement of the iris against the cornea. And so what I want you to do so that you visualize this, go to the diagram in your assessment book, locate the cornea and the iris. When you note these two structures, find the canal of Schlemm, and if you visualize what happens when these two structures move against each other, they close, and then the angle closes the canal of Schlemm once these two structures, converge on one another. They close the canal of Schlemm. And so when that happens, when they close that canal, then aqueous humor can't flow out of the canal. So they have increased pressures to occur. So we know with glaucoma, we're talking about increased intraocular pressure. But again, we're talking about two different causes. With primary open angle, we have blood vessel constriction, and you can't have and there's no outflow of aqueous humor. This is why the person has the increased pressure. With angle closure glaucoma, you have closure of the canal of Schlemm. It becomes obstructed, and then the person can't have the outflow of aqueous humor, and this is why the increased pressure occurs. And so when a person has glaucoma, with the primary open angle glaucoma, what the book says, the person, early on, the person may not have any signs and symptoms of it. They may go along life having no problems. One of the ways to determine the person is starting to develop glaucoma is by having yearly eye exams. And so with the yearly eye exam, the ophthalmologist should test the pressures behind the eye, not within the eye, or test the intraocular pressure. And so we say that the normal intraocular pressure is 10 to 21 milliliters of mercury. A person that has glaucoma is going to have a higher intraocular pressure than that 21 that I just mentioned. So some of the signs and symptoms, especially when the person has the acute angle closure glaucoma, the person may have sudden severe pain, they may have nausea and vomiting, and they may complain of seeing colored halos around lights. And so what should be noted with the acute closure is that it is sudden and severe. And with this one, this is a medical emergency, and we usually go ahead, and this person usually goes to surgery to get this one fixed. Again, with the primary kind, the person usually has no symptoms. So this is why it's important for patients, especially with hypertension or diabetes, to have yearly eye exams to test the intraocular pressures in their eyes. Excuse me for just a second. So now, although the person with the primary type may not have early symptoms, what's going on while the person is not experiencing symptoms is that tissue damage is starting to occur. And so the tissue damage, the way I think about it, it starts from the outside and works its way in. And so the tissue damage starts at the peripheries, starts in the periphery. So if we think about our peripheral vision, this is us looking straight ahead but being able to see things to the right and to the left of us. So the person with glaucoma, they start to lose peripheral vision first. And so one of the ways that we test peripheral vision is with the 6 cardinal fields of gaze, which is discussed in your assessment chapter. So how do we determine that the person has glaucoma? We just said, we learned about 2 different types of glaucoma. The person can have the acute type, or the person can have the primary type. So we have to determine or be able to distinguish between the 2. And so an ophthalmoscopic exam can help to determine and identify if it's angle closure. Now with tonometry, this is what is done when we go to have our eye exams, where they test the pressures. So again, the normal is 10 to 21. With open angle glaucoma, the primary open angle glaucoma, the person may have a pressure that's 22 to 32 milliliters of mercury. With the angle closure, the book says that the person may have 30 or higher with the acute angle closure type. Perimetry is what's done to test the visual fields. And so again, I said that the person with glaucoma, once that damage starts to occur, it affects the peripheries first. And so perimetry is a test that's a computerized test of the visual fields. When we test the 6 cardinal fields of gaze, this is us standing in front of the patient, taking them through a series of eye movements. Gonioscopy is what you see here. This top picture is an image of gonioscopy. And so this is done to test, this is used for patients that typically have high intraocular pressures. And so this test is done to determine if the angle is open or closed. Okay? So gonioscopy may be done in addition to tonometry, because tonometry is only going to tell us if the person has increased pressure. Once we know the person has increased pressure, then we have to determine if the angle is open or closed, and gonioscopy can tell us that. Now, this last thing, this is a picture of optic nerve imaging. And so optic nerve imaging is performed to determine if damage has occurred to the optic nerves as a result of the increased pressure. And so by imaging the optic nerves, the doctor can determine if the person has lost those optic nerve fibers. So all of these tests can be performed for the patient that has glaucoma. And so when we talk about glaucoma treatment, what happens if we don't treat glaucoma? Well, the person is going to go blind if we don't treat it. The person loses peripheral vision, and then that can progress to the person losing central vision. And glaucoma usually affects both eyes. So before we even talk about that, well, the first treatment of glaucoma is prevention. And so the way that we prevent it is the person, of course, treating blood pressures, keeping blood sugars within normal range. This person, once it's diagnosed, however, this person is going to use eye drops, and they're going to use eye drops on a daily basis. And so the eye drops will prevent further damage, but they don't improve the vision that the person has already lost. There is a chart in your book that goes over the different medications that are used in treatment of glaucoma. In this book, it's page 1099. And so even if we change books, I'm going to go over each medication. And so what you should do is make sure you go over these medications, look at the nursing implications and the rationales. The reason it's important for you to make sure you go over the rationales, as you see here, some of the medications that we use, you have some adrenergic agonists, and then here you have beta-adrenergic blockers, your beta blockers. And we know that we typically use those for patients that have high blood pressure. And so it's important for us when we have a patient that's taking these different types of medications to know what other disorders the patient is being treated for. Because if we're giving them a beta-adrenergic eye drop and also a beta blocker for their blood pressure, this person may have an unsafe drop in their blood pressure. Also, we need to know if the person is being treated for asthma, if the person has asthma, because beta blockers can cause constriction of bronchioles. So we have to know what other disorders our patients have and what other medications they're taking. Some of these medications can cause hypoglycemia. Your beta blockers can cause the person to develop hypoglycemia. So again, make sure you're reading over the nursing implications and rationales of these medications. Now, we're going to give the person with glaucoma, we can try a number of different different eye drops. And so these medications are going to do a number of things. They can reduce the production or increase the absorption of aqueous humor. So your prostaglandin analogs, these are medications such as your Xalanthan. Xalanthan is spelled Xalatan. Lumigan is Lumigan. These are different types of medications that are prostaglandin analogs. And so these medications work by increasing the outflow of fluid out of the eye. And so with beta blockers, timolol is a type of beta blocker that we use for glaucoma. And so these medications are going to work by lowering intraocular pressure by reducing the amount of aqueous humor that is produced. Okay. Then you have your alpha agonist, and so the alpha agonist, alpha-GAN is a type of alpha agonist, and it works to both decrease the production of fluid, and it also helps to increase drainage. Then you have your carbonic anhydrase inhibitors. Diamox is a type of CAI, or carbonic anhydrase inhibitor. And so the way that these medications work is that they reduce eye pressure by decreasing the production of intraocular fluid. So again, all of these medications are discussed in your book, so make sure you go back over your medications, look at your nursing implications, and your rationales for these medications. Now we're going to move on to talk about retinal disorders. So we're going to discuss macular degeneration, also a retinal hole, a retinal tear, and retinal detachment. Okay, macular degeneration. First, we need to talk about the macula. And so the macula of the eye is the area of central vision. The macula is the optical center of the retina. And so the macula is the area of the retina that provides sharp central vision. It receives light from the center of the visual fields. Okay. Macular degeneration, we know what degeneration means. It's something dying. And so we know that if the person, if the macula dies and it's the area of central vision, well, then it's safe to say this person has, lost their vision. So there are two types of macular degeneration. There is a non-exudate or a dry type of macular degeneration, and then you have an exudative macular degeneration, or what we call a wet type of macular degeneration. And so the most common type is the dry type. And so with the dry type of macular degeneration, the person has an accumulation of yellow colored deposits. These yellow colored deposits are called drusen, and that's D-R-U-S-E-N. It's in your book. And so the person will complain that they have spots in their vision. Well, that's because these yellow deposits have occurred within the retina. And so with the wet type of macular degeneration, the person has blood vessels in the eye that start to leak, and once these blood vessels start to leak, it leads to scar formation. And so this person is going to require, of course, a diagnostic exam, and so the diagnostic exam is going to determine if the person has the wet type of macular degeneration or the dry type. And so what the person is looking for on the diagnostic exam is the drusen, which would be the yellow colored deposits, or the ophthalmologist would find abnormally located blood vessels. And so that's going to help to determine if it's the wet form or the dry form. And so when we're talking about treatment of macular degeneration, really the person, they're trying to help the person maintain use of the vision that is left. Even with laser treatments, which is usually used for the wet type of macular degeneration, it's helping to stop the person from losing any more vision. But the person, once they start to lose vision from macular degeneration, there is no way for that person to regain that lost vision. So in your book, it talks about the person, it talks about laser therapy, photodynamic therapy for the wet type of macular degeneration. So just make sure you read over that. With retinal detachment, with retinal detachment, the person can have a hole, a tear, or an actual detachment of the retina. And so we know that's not a good thing, because the retina is responsible for our central vision, our peripheral vision, and our color perception. So if the retina is totally damaged, then we won't have any of those things. When we talk about retinal detachment, this is when a person has a separation of the sensory retina and the underlying epithelium. The person then has fluid to accumulate between these two, between the two layers. With holes, a hole can occur spontaneously. Tears may be due to increased traction, which exceeds the force of the retina. And so with that increased traction, this is going to lead to breaks in the retina, and then vitreous flows flows into the tear. And so risk factors for retinal tears, holes, or detachment are retinopathy, vessel changes. Retinopathy, we've probably heard of diabetic retinopathy that can occur. And so changes that occur to the vessels and blood flow to the vessels can affect the retina. The characteristics or the signs and symptoms that the person may complain about, the person may complain of light flashes, loss of peripheral or central vision. Well, that makes sense because we know that the retina is the center or the area of the eye where we get central and peripheral vision and color perception. So the person may complain of a loss of peripheral and central vision. And something else characteristic of a retinal tear or detachment is that the person is going to say it seems like a curtain is coming down over the eyes. We can test the person's near and far vision. We want the person, while the person is awaiting surgery, because this disorder or this retinal disorder will require a surgical procedure. We want the person to be on bed rest because it's going to reduce pressure and traction and prevent any further detachment. So we want this person to rest while they're waiting to have surgery. And so scleral buckling is one of the procedures that's discussed in your book for treatment of a retinal detachment. So make sure you read over that and care of the patient after retinal detachment. So there are different types of retinopathy that are discussed in your book. You have the hypersensitive retinopathy, and this is the kind that occurs from a person having high blood pressure. And then you have diabetic retinopathy that occurs as a result of diabetes. And so what diabetes does, the reason diabetes causes retinopathy, when you learned about diabetes, you learned that diabetes can cause macroscopic macrovascular changes and microvascular changes. And so the eyes is is the place where diabetes causes a microvascular change, because these are small vessels. And what the high levels of blood, the high glucose levels, what they do over time is that they cause the vessels in our heart, the vessels in the kidneys, and also the vessels in the eyes. It causes them to become hard or become what we call sclerotic. And so if you think about sugar, if we leave the top off of a canister of sugar, after a while, once air hits it, it becomes hardened. And so think of the vessels the same way. If we have these vessels over time and they come into contact with these high levels of glucose over a period of time, then it's going to cause those vessels to become sclerotic or to become hardened. And so as a result of that, it's going to affect the amount of blood that gets to that area, or in this person's case, it's going to cause retinopathy and change the retina, change the ability of the retina to properly do its job, because it's affecting the blood supply. Well, we know that the retina is responsible for, again, peripheral vision, central vision, and color perception. And so now it makes sense that when we have patients that are severe diabetics that don't have proper glucose control, well, then we have diabetic patients that develop diabetic retinopathy, and then they end up losing their sight over time. And so we just talked about macular degeneration. And so what you're going to do is go back in your book and just read over. It's a really small section where it talks about macular degeneration. There's really not much that we can do for macular degeneration except for putting the person into contact with some type of outside resource to make use of their limited vision. Now, with the ocular melanoma or cancers of the eye, retinoblastoma, is a rare cancerous tumor of part of the eye called the retina, of the part of the eye, called the retina. And so the definition of retinoblastoma, it's usually caused by a mutation in a gene controlling cell division. And so with this type of cancer, it usually develops in children. The cancer generally affects children under the age of 6. It's most commonly diagnosed in children's age 1 to 2. With the symptoms, the person may have one or both eyes affected. And so what it looks like is that the pupil may appear white or have white spots. A white glow in the eye is often seen in photographs taken with a flash. Instead of the typical red eye that we may see on some pictures with the flash, this person's pupils may appear white or distorted. Other symptoms can include crossed eyes, double vision, the eyes don't properly align. The person may have eye pain and redness, poor vision, and differing iris colors in each eye. If the cancer is spread, then the person may have bone pain. What can be done for this type of treatment? With small tumors, they can be treated with laser therapy or cryotherapy. The person can have radiation. Radiation can be used for local tumors. And the person may need chemotherapy if the tumor has spread beyond the eyes. Ultimately, the person's eye may have to be removed if the tumor does not respond to treatment. And so as far as the prognosis for retinoblastoma, if the cancer has not spread beyond the eyes, then the patient can be cured. A cure, however, may require aggressive treatment and even removal of the eye in order to be successful. So, with our refractory errors, we have myopia, which is what we call nearsighted. And so, if a person is nearsighted, that means that they have near sight. They can see things that are near to them. And so, a person that's nearsighted has an inability to see objects at a distance. And so when a person has myopia, and I really want you to look at this chart, the picture of this in your book. It's in the assessment chapter. It tells you that when a person has myopia, then the light rays fall in front of the retina. And so the book says that the person that has myopia, then this person needs a biconcave lens. And so that's a lens that's curved in on both sides. And what that does is help to focus those light rays directly on the retina. When a person has hyperopia, this is a person that's farsighted. And so the person, this person has an inability to see objects that are at close range. That's kind of odd. They can see things that are far away, but if they have a book in front of their face, then they have problems visualizing things that are close to them. And so that a person that has hyperopia, this person, the light rays fall behind the retina. And so this person has a convex lens. And one of the other things, one of the ways that I describe this to students, and it's kind of crass, I know, back in the day we used to say the person had a Coke bottle lens. And so the convex lens curves out. It's a thick lens sometimes. Well, and they, due to technology, they found ways to, make those thick lenses not look so thick. But the convex lens curves out, and that curvature of the lens helps to pull that light ray that's falling behind the retina. It curves it back out so that it falls directly on the retina. Now, presbyopia is the normal loss of near vision that occurs with age. And so this happens because, as it says here, the lens loses its elasticity. And so a Jaeger chart is what we use to test for the loss of near vision. So this is a Jaeger chart, and then you have the Snellen chart, which is what we typically see being used at the doctor's office. And so if you'll notice here, you see the 2200 and the 2100 and going on down to 2010. And so the way that we use this chart, the Snellen chart, is that, let's say that me and a student stand side by side. All of you know that I wear glasses. So let's say I have a student with perfect vision, that they don't need glasses or contacts. The way that we use a Snellen chart is that if me and this person are standing side by side and we're looking at this chart, the person with perfect vision can see, let's say, from 50 feet what I can only see from 20 feet. So let's say both of us are standing 20 feet away from this chart. I can probably read this line, but the person with perfect vision, they can move back 30 more feet and still be able to visualize this line. So this is how we use the Snellen chart. Now, another term that's not on here is strabismus. And strabismus is a condition when a person cannot consistently focus two eyes simultaneously on one object. With astigmatism, it says here it's a curve of the cornea is uneven. And so when the person has uneven curvature of the cornea, well, then it causes the person's vision to be distorted. So this person may require corrective lenses to correct an astigmatism, either glasses or special contact lenses. So again, we have the Jaeger chart that's used to test for presbyopia. And then we have the Snellen chart. Okay. So with different types of eye trauma, you see here, a person can have a hyphema. And so a hyphema is when a person has bleeding into the anterior chamber of the eye. It could be the result of a blunt eye trauma. And so when the person has this to occur, the person may complain of eye pain, decreased visual acuity, and the person may say that they see a reddish tint. And the person may also have blood that's visible in the anterior chamber of the eye. Also, it may be noted that the person may complain of pain when they move the eye upward, and the eye may appear to have a sunken appearance to it. And so really all a person can do with a hyphema is that the person can rest the eye. The person can rest the eye and use cycloplegic drops that are going to reduce movement of the eye. The person, according to the book, is encouraged to maybe wear an eye patch, but they really want to rest the eye, and then the symptoms should resolve themselves in 5 to 7 days. Now, a burn can occur, of course, if a person is involved in a fire. A burn can occur from heat, radiation, or an explosion. But chemical burns are the most common type of burns that occur to the eye. Things such as ammonia, acids from batteries, different type of oven and drain cleaners that we use, household things are usual chemical burns that a person may have that occur to the eye. And so what we want to do when a person has a burn to occur, well, one of the things that we want to do is make sure that the person is properly doing what should be done for that. And what I mean is that we want to make sure that we read the side of the container. Let's say it's oven cleaner. The first thing we want to do before we before we take the person to the hospital, what does the side of that can say? Does it say to apply water, or does it say to cover the person's eye and immediately transport them? The reason that's important, because sometimes we add water to things that don't need water. For example, I heard of a case before where a child ate kitty litter. And so the mom, usually we tell the person to drink some water, drink some milk. Well, we know that with kitty litter or things like that, when you add fluid to them, they swell. And so the child ended up dying. And so what we always want to make sure when we have a child ingest something splashes on the skin or splashes on the eyes, what does the side of the can say? Do we add water? Sometimes if you add water to an acid, that's a bad thing. So we want to know what the side of the can says, what the container says for that solution. But we want to make sure that we're taking that person to a medical facility. Okay. Now, we already talked about keratitis a little. We talked about keratitis where the person had an infection of the cornea. With the corneal abrasion, this can happen from contact lenses, eyelashes, small foreign objects, or foreign bodies such as dust or a fingernail. And so, although it's painful, they usually heal without any type of complication or scarring. The person may have blurred vision or tearing in the immediate period, but these areas usually resolve themselves without any complications or scarring. With penetrating bodies, it's just what it sounds like, something that's in the eye, maybe a gunshot, an arrow, a knife, something that's penetrated the eye, and it's in the globe, actually in the globe of the eye. And so with penetrating injuries, what we want to do is that when the eye is lacerated or has a puncture wound, inspection of the underlying eye tissue is going to be done by the physician to see if there is possible damage. And, it makes sense that if the person has a gunshot wound, they are going to have damage. What I've read in different books is that if a person has a type of penetrating injury, let's say the person gets something in the eye while they're home, something flies in the eye. I've read in different books that you aren't supposed to remove that until the person is in the emergency room. The person may need surgery to remove the foreign object, but our book doesn't necessarily say that. But I would think if the person has something jagged in the eye, that we want to cover that area until we can safely transport them to an emergency facility, and then they would, do what's required to the eye, such as surgery. The person may need antibiotics or a tetanus shot after this procedure. Definitely antibiotics to cut down on any type of infection. With a conjunctival hemorrhage, this can occur from increased pressures. They can happen spontaneously. Hypertension is a reason that a person can develop a conjunctival hemorrhage. They usually resolve themselves in 14 days without treatment. They're usually not painful. The person doesn't have a visual impairment. But if the person has not done anything, let's say they haven't been straining, this can be one of those signs and symptoms to lead this person to seek a physician's treatment. if a person does not know that they have hypertension, this could be one of the signs to let them know that they have hypertension. Also, if the person is taking hypertensive medications and this just automatically, spontaneously happens, well, then it may mean that their pressures are not being controlled adequately, and the person may require a change in their medications. Also, the book says that a person can have, a person that is taking blood thinners could also develop a conjunctival hemorrhage. So this may be a person that requires a change in their medication regimen. So even though they can resolve themselves within 14 days, the person should still, I think the person should still seek medical attention just to make sure that their pressures are under control and that they don't need any change in their medications. Now, with reduced vision, as it says here, interventions are going to include communication regarding the use of adaptive items, because we know we have a lot of patients that, may live by themselves, and so they're going to need some type of adaptive items to be able to function within their environment safely. They're going to need safety in familiar settings, and so in their home, they're going to require more help and more assistive devices in their home, maybe guardrails. Maybe the person is going to have, if they live alone, they may need to have more lights installed in their home care environment. If we know that we have a patient and they have decreased or reduced vision, of course we want to help them with ambulation and assist them with care. We always want to promote self-care and as much independence as needed. We have a person that has reduced vision and maybe they need assistance with eating. We've learned before maybe about the clock method, and this is telling the person, okay, we imagine that the food is divided into sections like a clock, and we say, okay, at 3 o'clock you have your peas, at 6 o'clock you have your roll, and at 9 o'clock you have your meat. And of course we can help them and tell them to your right is your silverware and to your left you have your juice. And so we can help them by setting those things up for them and telling them where their things are. So when we have a patient that's blind, I have this is a link here I want you to go to, and so this link tells about the care of a prosthetic eye, and so there are ways that a person should care for a prosthetic eye, and there are procedures for taking the eye out. It needs to be cleaned on a regular basis, and so I want you to go to that site and read that information. When we have patients that are blind, however, we want to always foster independence in our hospitalized patients. And so, again, we want to make sure that we orient them to their environment, tell them where things are in their environment. We can describe the room to them. We know that the person, we don't know how much sensory we want to tell the person about the different things within their environment, such as chairs, their personal items, clothing. We want to describe what's going on around them. We always want to introduce ourselves when we enter the room and let the person know when we're leaving. Okay, that's just common courtesy, so the person isn't talking to themselves. We want to provide other sensory stimuli such as the radio and the television if the person desires. I already talked about orienting the person to their food trays using the face of a clock or the clock method. We always want to assist them with ambulation as needed, and so we want to allow the patient to hold our arm as we walk slightly ahead. We don't pull the patient's arm. We allow them to hold our arm and we guide them. Okay? And so we want to verbally describe the environment, such as we have 2 steps coming up and we're going to step up or step down. Okay, so we want to make sure that we're telling them of any obstacles that are upcoming. And so these are just some things that we can do when we're taking care of patients that are blind while they're in our care. And that ends our lecture on alterations of the eye. And if you have any questions, please email me.